Hello, I'm Dr. Maury Markman from City of Hope, and I would like to, over the next several segments, talk about my personal favorite topic, precision cancer medicine. A little bit of a historical view and what has recently happened, which I would say is an explosion of the process. So on this segment, a little bit about history. In fact, this is very, very old history. If you want to be honest about it, cancer therapy started with precision cancer medicine. Of course, we didn't call it that. We didn't understand it. It certainly wasn't molecular, but in fact, it was recognized many, many, many years ago that removal of the ovaries in a premenopausal woman with metastatic breast cancer could result in meaningful, even if short-term, improvement in the disease. In men, orchiectomies could lead to regression, short-term, but again, meaningful in metastatic prostate cancer. Of course, we now know that we were actually impacting a target. We know we were impacting the hormonal effects on cancer. So it was treatment. It was clearly precision. It didn't work in people without those particular molecular abnormalities. It wasn't understood at the time. Of course, we advanced with the development in breast cancer, specifically with the estrogen receptor, the progesterone receptor. Again, not molecularly based, but we could identify through immunohistochemistry the presence of these receptors. The more of them present on the surface of the cancer cells, the more likely the hormone therapy would work. That obviously introduced this whole area. And it was restricted to those tumor types where we could actually find these abnormalities. Again, not detecting them at a molecular level, but certainly finding the product and being able to demonstrate that presence of that product, which led then to a prediction of whether a particular therapeutic strategy would work or not. Obviously, in breast cancer, we then saw the introduction of looking at the presence of another abnormality, HER2, and to HER2 overexpression. The more HER2 is present, the more likely that inhibition of that particular molecular effect would have an impact on the cancer. In the hematologic malignancy world, of course, the understanding about BCR-ABL, its central role, the concept of oncogene addiction, which was unfortunate because that was a unique situation where that abnormality was necessary for the tumor to progress, as opposed to other tumor types where resistance can develop, became a theme of looking for, if you can find a target, you can treat the cancer very effectively, and overexpression of a particular target was thought to be where we needed to go. Next time, I will talk about how we fortunately quickly pivoted from that overly simplistic view of molecular targets on to where we are today. I thank you for your attention.